Okay, folks, so now we're going to move and talk about metabolism. So let's spend a little bit of time on this slide. This is a depiction of the model of drug disposition. So over on the left, we have an oral dose of a drug being administered. The drug is then absorbed. So what we're not showing you is the absorption slides that we discussed previously, but the drug is absorbed into plasma. The drug may go through a variety of different routes. It can be bound to plasma protein, shown here. It can be stored in adipose tissue, shown here. It can be bound to receptors, which we haven't yet talked about. And receptors are typically where we want the drug to go. So binding to receptors in target tissue. In addition, down here, we are showing the intestine, where you can have a drug that has been provided or sent to the liver, and instead of the liver redistributing that drug back into plasma up here, the liver may actually attempt to excrete the drug in bile, in what we call the enterohepatic circulation. And we will come back and talk about this at a later point in this series. Drugs from the liver can be sent to the kidney, can be sent back into plasma, can be sent essentially around the body. Also keep in mind that we talked about inhaled medication or even intranasal medication. But let's take inhaled medication. So inhaled medications are shown here. So drugs can actually enter into the lung from inhaled medications, but also can be exhaled or expired volatile metabolites of drugs. So we see this interplay between drugs moving from the lung to free drugs in plasma, drugs moving from the kidney to free drugs in plasma. And note, these are bidirectional arrows that we're looking at. Drug moving from the liver back into plasma, bidirectional arrow again. Drugs moving from being bound to plasma proteins to being free drugs in plasma, bidirectional arrow. So this concept of drug disposition really tries to emphasize the fluidity of drugs in the body. So drugs are moving, they're not static. They're going to be bound, they're going to be unbound, they're going to bind to their target receptor, they're going to be unbound to their target receptor, they're going to be stored, they're going to be released, they're going to be excreted, they're going to be reabsorbed. It's this constant dynamic that is referred to as drug disposition. Now, one aspect of this is drug metabolism. Is what are the elements of drug metabolism that play into this whole picture? So we use the term biotransformation and metabolism interchangeably. Biotransformation is this concept of change, transforming. Bio, it's occurring in the body. Metabolism is also this concept of converting a molecule to another molecule. So biotransformation and metabolism are interchangeable terms. We appreciate that metabolism can essentially occur anywhere in the body, but we also understand that the vast majority of biotransformation occurs in the liver being one of the most critical organs in the body for this and many other reasons. What's the purpose of biotransformation? Well, the answer to that is actually several different reasons. The most important is to inactivate a drug. How's this done? Well, it's the conversion of the active drug into a more excretable form. Typically, we make drugs more polar so they can be excreted by the kidney. Most drugs require biotransformation in order to be excreted, but not all drugs. Some drugs are excreted in exactly the same way in exactly the same form as they were administered, but most drugs require some degree of metabolism or biotransformation in order to be excreted. So think of this for a second. We do have some examples in clinical medicine where drugs are administered as inactive compounds. These are called prodrugs, and they require biotransformation to become active. A very good example of this is the proton pump inhibitor Prilosec. Prilosec is a drug used in the treatment of gastroesophageal reflux disease and peptic ulcer disease. It is administered as a prodrug and gets converted into its active moiety after absorption. Some drugs are metabolized to actually deliver more active drugs. So many of the drugs that are used in anesthesia and many of the pain medications and the anti-anxiety medications are active in the form in which they're given to the patient, but part of the metabolic process produces active metabolites. This can be challenging because it can be difficult to actually quantify how much of the clinical response, the pharmacodynamic response, is from the drug that you administered or from the active metabolite. And then some drugs, as I said previously, are excreted unchanged. So metabolism is a process whereby drugs are changed after administration. Typically occurs in the liver. Primary purpose is to make the drug into a more excretable form and thereby terminating the action of the drug, but can also include converting prodrugs into active drugs or the conversion of active drugs into equally less or more active metabolites. Where does it occur? So what this picture is attempting to show is different types of metabolism occurring in different tissues. And I'm going to highlight this one right here. This, the arrow showing the liver, refers to the vast majority of biotransformation that occurs to result in excretable molecules. The enzymes that are responsible for this are primarily housed in the liver and are referred to as the hepatic microsomal enzymes. The types of reactions that they catalyze are oxidation reactions, and we're going to talk more about that in one moment. These microsomal enzymes aren't confined to the liver. They're also found in other tissues, and that's what you're seeing referred to here. So extrahepatic microsomal enzymes. They exist in the brain, they exist in muscle, they exist in the kidney, they exist in the heart, to a lesser extent in the lungs. They are found throughout the body. And then you have a second type of enzyme systems, metabolic systems that exist in the liver that are called non-microsomal enzymes. And these are referred to as conjugation steps. They typically occur in the liver, and that's shown in this box down here, and they involve adding something to the drug to make it more polar or more excretable, colloquially referred to as conjugation, combining something together with something else. So I'm going to share with you now some general concepts about drug metabolism. So it can occur in two ways. These two ways are referred to as phase 1 and phase 2. Drugs may be subjected to only one of these two. It may be subjected only to phase 1 or only to phase 2. Drugs may be subjected to both and may be subjected in any sequence. What's phase 1 metabolism? Well, this is that microsomal oxidation system. Phase 1 metabolism occurs by oxidation and involves this family of oxidative enzymes, and it is called the cytochrome P450 system. And I would strongly recommend that you remember that term, the cytochrome P450 system, also sometimes referred to as CYP for short. Phase 2 metabolism involves coupling to an endogenous substrate or a drug, phase 2 metabolism involves coupling an endogenous substrate to the drug or to the phase 1 metabolite. So what are the sorts of substrates that you get the drug coupled to? Well, you can couple it to an acetyl group. This process is not too surprisingly referred to as acetylation. You can couple the drug to a glucuronal group, glucuronidation, a methyl group, methylation, a sulfur group, sulfation, and then the extraneous odd guy out, the addition of glutathione using an enzyme called glutathione S transferase. So these are examples of phase 2 metabolism, conjugation, phase 1 metabolism, oxidation. A picture. Here's your drug in the center. Remember that slide on drug disposition? The drug can accumulate in tissue. It can be excreted unchanged. It can undergo biotransformation. And here you're looking at phase 1 biotransformation, and here you are looking at phase 2 biotransformation. So the drug subjected to phase 1 biotransformation, i.e. oxidation, cytochrome P450 system, those oxidative enzymes, are responsible for converting the drug into a phase 1 metabolite, with the idea being that the drug is now in a more excretable form and can undergo that process efficiently. Alternatively, the drug can undergo phase 2 metabolism, remembering that phase 2 metabolism involves conjugation, the addition of an acetyl group, a glucuronal group, a sulfur group, a methyl group, or the addition of glutathione. These all involve adding a compound to the original molecule to make it more excretable. Then, just to confuse you ever so slightly, the drug may undergo phase 1 metabolism first, and that metabolite can then undergo CYP metabolism. Or the drug can undergo CYP metabolism first and then undergo phase 2 metabolism to produce a phase 2 metabolite. These processes are interchangeable and can occur in any sequence. The primary purpose is to convert the drug into a more excretable form. Putting this into practice, using the drug acetaminophen. Acetaminophen is the active molecule in Tylenol that you purchase over the counter for the treatment of pain, headache, fever, etc. So here we have our active drug acetaminophen. Acetaminophen is an example of a drug that undergoes both phase 1 and phase 2. The phase 1 metabolism via the CYP enzyme produces a molecule, long chemical name, acetylbenzoquinonamine. This is an inactive compound, but it is not quite in an excretable form. This phase 1 metabolite needs to undergo phase 2 metabolism, i.e. conjugation, by the addition of a glutathione side chain, subgroup, to produce acetaminophen glutathione adduct. We now have an excretable form of acetaminophen, and this molecule is polar enough to be excreted. Alternatively, acetaminophen can undergo phase 2 metabolism in isolation by the addition of a glucuronide group or a sulfur group. And both of these products of glucuronylation or sulfation results in a compound that is excretable. So here is an example of one drug that can purely undergo phase 2 metabolism and be excreted, or undergo phase 1 first and then phase 2 second to produce an excretable compound. So this interaction between phases of metabolism, you can imagine, took a long time to elucidate. It's complex, it's interchangeable, and not always predictable. It's not always known, well, what percentage of a given drug will undergo phase 1 versus phase 2? How is it decided that a drug will be glucuronylated versus sulfated? A lot of those niceties of the drug metabolic processes aren't always concentrated on because in many cases it doesn't have an impact on the pharmacodynamic profile, i.e. the efficacy and the safety of the drug in question. So let's talk about oxidation just a little bit more, because this is actually an important concept when it comes to discussing pharmacogenomics. How does the genetic makeup alter the handling of medications? So let's talk about the cytochrome P450 system in a little bit more detail. So it is composed of many families of heme-containing isozymes. That's in part why it's called cytochrome. These isozymes are located in most cells, as said previously, but heavily concentrated in the liver and also in the gut. Carbon monoxide binds the reduced hemoglobin of the isozyme and absorbs on a spectrograph at 450 nanometers. And this is why the nomenclature is cytochrome P450 system. You don't really need to remember that, but it explains the nomenclature. So these CYP enzymes are the major catalyst of drug metabolism, but also endogenous oxidations. So the CYP pathways are a critical enzymatic group of enzymes that are responsible for maintaining homeostasis in vivo. It helps in the metabolism of a large number of endogenously produced compounds, things that our bodies make on a day-to-day basis. But it is also a critical pathway for drug metabolism. And for those biochemists out there amongst you, this is the chemical reaction that we are talking about. We have the drug, we have a source of oxygen, a hydrogen ion, and an energy source. And we see the transfer of the hydrogen ion to the addition of this hydrogen ion and oxygen to produce water, and the transfer of the oxygen from the O2 to produce the oxidized drug. And it is this oxidized drug that is inherently more polar, dissolvable, and excretable, most commonly through the kidney. So an example of a biochemical pathway to help explain the functionality of the cytochrome P450 system. Now this is a huge family of enzymes, and therefore there is a value to appreciating the nomenclature in somewhat greater detail. So what I am showing you here is an example of just one CYP enzyme, and this is CYP2D6. So what do all these 2D6 letters mean? So this first number here refers to the family number. And we talk about homology of amino acid sequence quite often in pharmacology in general. So the family of the CYP enzyme bear pretty decent similarity between them. So 40% homology of amino acid sequence amongst these enzymes. Then we have a letter in here. In this case, it's D. And this is the subfamily, the letter. And this demonstrates, on average, a 55% homology of amino acid sequences to others within this family. And then finally, often, but not always, you have a number, an additional numeral for individual isozymes. Now, these isozymes generally have overlapping specificity. So you may have an isozyme that has the numerical distinction of being 6 versus 5, and these two enzymes will have some degree of overlapping specificity for metabolizing a particular endogenous compound or a specific drug. So this is where the nomenclature comes from. CYP2D6 is an example of a cytochrome P450 enzyme that is responsible for the metabolism of a very large number of drugs that we use in everyday clinical practice. In all, there are 12 CYP families that have been identified in humans. The likelihood is that there are more that have yet to be identified. From the perspective of drug metabolism, most of the enzymes fall into the 1, 2, and 3 families. And the big player, the one that we've spent a lot of time paying attention to, is CYP3A4. And I would strongly recommend that you learn about this particular enzyme because it is considered to be responsible for the metabolism of many drugs. I'll take a sidestep here and just share with you that it is not uncommon for us as providers or prescribers not to know the metabolic pathway of some of the drugs we use in medicine today. Even though we strive to try and understand the pathway, there are certainly situations where this information is not available. But of the examples that we do know, the metabolic pathway in great detail, CYP3A4 is an important isozyme. In fact, CYP3A as a group is an important group of enzymes as part of the CYP family. Now let's get back to genetics just ever so slightly. We appreciate that there are inter-individual differences in the level of activity of these enzymes, and that these differences in the level of activity can actually result in differences in drug metabolism. And to give you an example, CYP3A4 activity in the GI tract can be highly variable, and it can be a cause of poor oral bioavailability of drugs that are substrates for this particular enzyme. Let's delve into CYP3A4 in greater detail for a moment. One of the key aspects of this particular enzyme is that its activity is highly variable. And it's highly variable in different artificial circumstances. So for example, this isozyme can be induced, i.e. its activity increased, in the presence of a drug called rifampin. This is a drug that's used in the treatment of tuberculosis. In addition, the activity of the drug can be increased or induced by an herbal remedy called St. John's wort. I'm sure many of you have heard of this. The active ingredient in St. John's wort is called hypericum, and it is commonly used as a mood stabilizer. In fact, our information about St. John's wort led to the development of a class of drugs used in the treatment of depression called serotonin reuptake inhibitors. The increase in the metabolism of drugs that depends on this isozyme, CYP3A4, can lead to those drugs having decreased efficacy. And I'm going to give you an example of that. So this particular publication, believe it or not, is now 12 years old, was published in The Lancet, which is, as you all know, a premier medical journal, and it is essentially a case report or case series. It represents an experience with two patients, both of whom had received heart transplants. Now, I said previously that people who are transplant recipients are commonly managed, or I should say always managed, with immunosuppressive therapy. And one immunosuppressive drug, which has been for many years the mainstay of therapy for many patients who are organ recipients, is cyclosporin. And cyclosporin is an immunosuppressive agent. Cyclosporin is metabolized by CYP3A4, key enzyme involved in the metabolism of cyclosporin. In addition, cyclosporin levels in plasma need to be controlled very carefully, because if you over-immunosuppress a patient, they can get deadly infections. If you under-immunosuppress a patient, the organ that was transplanted could be rejected. So it's a little bit of a dance with Mephisto, a balance between preventing rejection and preventing superinfection. So we have patients who are treated with cyclosporin. This particular report in The Lancet described a story of two different patients who were receiving cyclosporin as part of their immunosuppressive therapy following their heart transplant. These patients were taking St. John's wort. It's a supplement. In both cases, the physicians are described as not knowing that the patient was taking the supplement. In both of these cases, St. John's wort increased the activity of the CYP3A4 enzyme. It induced the activity of the CYP3A4 enzyme. The net effect was the immunosuppressive drug cyclosporin was metabolized more rapidly than would have occurred in the absence of St. John's wort. Both of these patients experienced an episode of rejection. I share this particular example with you. It's but one of many, many reports in the literature because it really highlights the clinical importance of understanding pharmacokinetics. CYP3A4, as I said previously, is a key enzyme. This is an example of a supplement having a very negative sequelae on two patients' outcome in pretty critical situations. Another example is the effect of the same drug, St. John's wort, on indinavir. Indinavir is a drug that's referred to as a retroviral agent. It's used in the management of patients who are HIV positive. Indinavir is highly dependent on CYP3A4 for its metabolic pathway. In the same sort of scenario, subjects or patients who were taking indinavir were also subjected to St. John's wort. The St. John's wort increased the rate of metabolism of indinavir. And let me walk you through this particular depiction. This solid line here is indinavir on its own. So this is a group of research subjects who were on their routine regimen for indinavir. This shows the plasma concentration of indinavir in their bloodstream, and this shows the effective time. So the plasma concentration as a function of time. Indinavir on its own, indinavir together with St. John's wort. And what you are essentially showing is the plasma concentration of indinavir in the setting of St. John's wort, A, reaches a much lower peak, and B, is metabolized much more rapidly. So do you remember we talked about area under the curve? In the absence of St. John's wort, the AUC is, roughly speaking, twice the AUC in the presence of St. John's wort. And the concern, of course, here would be what would the impact of this pharmacokinetic principle be on the pharmacodynamic effect of the drug? So for indinavir, it's used in the management of patients who are HIV positive. CD4 counts is a marker of efficacy of these drugs. The CD4 counts are at risk of increasing if indinavir is taken in combination with St. John's wort. And this is an important interaction because of the common coexistence of depression in patients who are HIV positive that is seen in clinical practice. So healthcare providers being aware of supplement use in addition to prescribed drugs is also an important learning point from these two examples that I have just shared with you. Well, what about the contrasting example? What happens if the activity of CYP3A4 is decreased instead of increased? So in this scenario, your concern is that the drug that you've administered that is dependent on CYP3A4 won't be metabolized. So you could imagine two pharmacodynamic sequelae here. The pharmacokinetic effect is decreased metabolism. The pharmacodynamic effect might be increased efficacy, or it might be increased toxicity, or it might be both. Or indeed, it might have no impact whatsoever on the pharmacodynamic profile. So what do we know actually does decrease the activity of CYP3A4? Well, I think many of you have heard about grapefruit juice. So grapefruit juice in reasonably large quantities can dramatically reduce the activity of CYP3A4. This will decrease the metabolism of the drug, which can lead to either a prolonged effect or, and maybe in combination, an increase in toxicity. So I'm going to share with you a very interesting series of data. This is a study that was published in the British Journal of Clinical Pharmacology now a long time ago, back in 1998. And what these investigators showed was the alteration in plasma concentration of a drug called felodipine. Now, felodipine falls into a class of drug called calcium channel blocker. It's used much more commonly in Europe than in other continents. It is used as an antihypertensive drug for the treatment of high blood pressure. And what the investigators did here was they took a group of healthy individuals and they asked them to swallow a dose of felodipine, 5 milligrams, which is a standard antihypertensive dose for this drug, and to swallow it with either water or with grapefruit juice. And they did a head-to-head comparison. One group swallowed with water, one group swallowed with grapefruit juice, and they compared the plasma concentration shown here on the y-axis over time on the x-axis. And they demonstrated something pretty similar to what we showed previously, that if you compare the plasma concentration as a function of time after swallowing the pill with grapefruit juice, not only is the area under the curve much greater than if you swallow it with water, but also the peak concentration achieved is much greater with grapefruit juice versus water. Now think about this for a second. What's the interplay between pharmacodynamics and pharmacokinetics here? So the pharmacokinetic principle is you get a higher plasma concentration and you get a higher area under the curve. The drug hangs around longer. The pharmacodynamic potential, of course, is this is a blood pressure lowering pill. So if higher concentrations are reached and the blood hangs around and the drug hangs around in the bloodstream for a longer period of time, well then maybe the blood pressure will be reduced to a greater degree. And that was exactly what was shown in this particular study. That not only was the pharmacokinetic correlation showed that grapefruit juice inhibited the metabolism of felodipine, but also it was manifest as a greater reduction in blood pressure in comparison to the same pill being swallowed in water. So then you ask yourself the question, where is the inhibition of metabolism actually occurring? So let's take a closer look at this. So first of all, let's start out here. So what the investigators set about doing was to extrapolate upon the previous finding and say, well, would it be different if the drug was given IV, intravenously, versus orally? You know, where is this altered metabolism occurring? Is it a reduction in metabolism, in other words, an inhibition of CYP3A4 in the liver, or is it occurring in the GI tract? Because remember what I said previously, these CYP enzymes, although heavily concentrated in the liver, also exist elsewhere in the body, most notably in the intestine. So what they did was they gave IV felodipine with water, IV felodipine with grapefruit juice. And here you can see swallowing a glass of grapefruit juice or swallowing a glass of water made no difference to the plasma concentration to a dose of felodipine given IV. Makes perfect sense, right? But what if you compare that then to giving the pill by mouth? So oral felodipine with water versus oral felodipine with grapefruit juice. So what can you infer from this? Well, I think the answer is actually kind of intuitive. That the inhibition of CYP3A4 is occurring locally within the GI tract. And in fact, it's GI inhibition in the endothelial cell, that cell that the drug is going to have to pass through to get into the portal circulation. This is where the inhibition of CYP3A4 activity is occurring. It's not in the liver. And that's an important concept. So if we can infer from this whole idea of grapefruit juice administration, it is an example of a food substance interfering with drug metabolism, whereas previously we showed you an example of a supplement interfering with drug metabolism. So I'm going to spend a little bit more time here, and I'm going to show you 3 sequential examples of how this interference in metabolic pathways, specifically CYP enzymes, can impact how much drug ends up in circulation or remains in circulation, dependent upon the bioavailability of the drug and where the alteration in metabolism occurs. So let's walk through these examples for a second. And I'm using slides that I've showed you previously. So here's an example of a drug that we give by mouth. And we're going to hypothetically say that this drug has a high bioavailability. So let's now start trying to tie all these concepts together. So remember, bioavailability is the concentration of the administered drug that ends up in circulation in an unchanged form. Okay? So here's your drug given by mouth. 10% of that drug undergoes biotransformation in the enterocyte. This is the lining of cells along the GI tract, right? So you've already lost 10%. An additional 10% undergoes biotransformation in the liver. So you've lost 10% here, and then you're losing 10% of the 90% that reached the liver. So let's hypothetically say we give the patient 100 milligrams of the drug. 100 milligrams of the drug is absorbed into the enterocyte. 10% of the drug is lost at this point, leaving a total of 90 milligrams, or 90% of the originally administered dose, reaching the liver. 10% of this 90 milligrams is now metabolized through the CYP pathway in the liver, biotransformation in the liver. This ultimately means that you're going to lose a further 9 milligrams, or 9% of the original, of that amount that reaches the liver. We are left with 81% of the original drug, or 81 milligrams of the original drug, being exported from the liver. And from this, we say the drug has 81% bioavailability. So this is an example of a drug that has high bioavailability. Now, let's say we come along and we give that drug with grapefruit juice. And we've just shown you in the previous example that grapefruit juice interferes with that metabolic process in the enterocyte. And I'm going to make it simple here and say that the grapefruit juice has actually obliterated the biotransformation that occurs in the enterocyte. In reality, it never obliterates it completely, but it diminishes it. So in this situation now, instead of 90% or 90 milligrams of the original administered dose reaching the liver, you now have 100% reaching the liver. And you lose 10% of 100 as opposed to 10% of 90. So you end up losing a smaller amount in total before that drug reaches the systemic circulation. So in the presence of grapefruit juice, hypothetically, your bioavailability goes from 81% to 90%. This is an increase of 11% in total. Now let's look at example number 2. In this particular example, we are talking about a drug that has low bioavailability, but that low bioavailability is due to hepatic metabolism, okay? Hepatic metabolism. So in this situation, we're giving the same drug. We're getting 25% loss of the drug due to biotransformation at the level of the enterocyte. So in this particular case, we're excreting 20 milligrams through the feces. We're getting an additional 80 being absorbed into the enterocyte. We're losing 25% there. 25% of 80 is a further 20 milligrams. And then we see that only 60 milligrams of the drug is actually reaching the liver. However, once this drug reaches the liver, it undergoes very significant first-pass metabolism, hepatic biotransformation. So the net effect here is we lose a further 45 milligrams of the drug. The net effect being that 15 milligrams of the original 100 milligrams of the drug that was given to the patient reaches the systemic circulation. And this would be an example of a drug that has 15% bioavailability. So now let's, in this particular example, imagine that we are taking the medication with a drug that interferes with the GI biotransformation, so using grapefruit juice again. In this situation, focus here. We're losing 25% of the biotransformation that occurs in this particular scenario. So what ends up happening here is instead of 60% ending up being transmitted to the liver, our 60 milligrams ending up being transmitted to the liver, you have 80 milligrams being transmitted to the liver. But in this situation, the majority of the biotransformation is actually occurring in the liver. So 75% biotransformation is going to occur at this site. So what's the impact of this in the setting of taking a medication with grapefruit juice? Well, instead of losing 45 milligrams of the originally administered drug, here you're actually going to lose 60 milligrams of the administered drug. So in this situation, your bioavailability is 20% instead of 15%, and this represents an increase of 33% in total. Now, example number 3 is the most extreme of all of them. So let's say we again have a drug with low bioavailability, but in this situation, it's due to intestinal metabolism. So if we move quickly through the first example, because it's the same as what I showed you in the previous slide, with one exception. We flip-flopped where the biotransformation is occurring. So in this case, 75% is occurring at the level of the GI enterocyte, and only 25% is occurring at the liver, at the level of the liver. So in this scenario, if you look at the whole pathway of the drug, 100% of the drug is, 100 milligrams of a drug is administered. 20 milligrams of the drug is excreted directly in the feces, not absorbed, leaving 80 milligrams of the drug to be absorbed through the enterocyte. The vast majority of biotransformation is occurring at this level. So 75% of 80 milligrams is going to be lost. This represents 60 milligrams here, leaving a total of 20 milligrams of the original 100 that is being absorbed through the portal circulation into the liver. This 20 milligrams of that drug is subject to 25% biotransformation through the CYP pathway in the liver, leaving a total of 15 milligrams, i.e. 15% bioavailability. Now, let's imagine that our patient has swallowed that same medication with a glass of grapefruit juice. And here's what we're going to end up with at the end of the day. So in this scenario, the biggest change is the reduction in the enterocyte CYP pathway of metabolism. So instead of that 75% markedly reducing the overall bioavailability of the drug, you get a much lower number. Hypothetically, in this scenario, we're saying 0. So instead of 20 milligrams of the drug reaching the liver, here we have 80 milligrams of the drug reaching the liver. And only 25% of 80 milligrams metabolism is going to occur at this site. So we are going to lose a total of 20 milligrams of the drug at this particular point. The net most marked difference is that 60 milligrams of this drug is going to enter into plasma in comparison to 15 milligrams in the absence of grapefruit juice. And this represents a difference of 15% versus 60%, a whopping 300% difference in bioavailability. Now, what's the best clinical example that I can give you of this in common day clinical practice? Well, I think many of you are aware of a group of drugs called statins, HMG-CoA reductase inhibitors. These are medications that are ubiquitously used throughout the developed world for the management of elevated cholesterol levels. Statins are dependent upon CYP3A4 metabolism for the most part, not exclusively, but for the most part. And it has been shown that patients who drink large quantities of grapefruit juice around the time that they take this medication have marked increases in bioavailability. And most importantly, this increase in bioavailability has been partnered and coupled with an increase in toxicity. So here is an example, and the toxicity is myopathy, muscle aches and pains. So here is an example where a pharmacokinetic principle, bioavailability, can be markedly altered by changing the degree of metabolism. In this situation, decreasing the activity of CYP3A4, resulting in a potential pharmacodynamic adverse effect, increased toxicity. Interestingly enough, it has not been reported that there is a marked increase in efficacy in a similar fashion. So with statins, the pharmacodynamic result of all of this has been demonstrated to be toxicity. Now, that's an extreme example of what I just showed you. There are varying degrees of this, and as I said to you previously, the way I've depicted this is absolute obliteration of the GI biotransformation, which in reality doesn't occur in clinical practice. So what I'd like you to take home from this is this concept of the potential of alterations in CYP3A4 activity as a virtue in this example of grapefruit juice. That can markedly alter the biotransformation of drugs. And in the previous example, the opportunity for a supplement, and the example I gave you was St. John's wort. Just so as we don't leave this topic with you believing that CYP3A4 is the only CYP enzyme that we really pay any attention to, that is certainly not the case. There are two additional ones, CYP2D6 and CYP2C19, that are very important in the metabolism of a wide range of drugs as well. And I show you this just to give you a sense of the spectrum of clinical conditions that use medications that are metabolized by CYP2D6. So here you can see it is an enzyme that is important in the metabolism of drugs used in the treatment of cancers, in people who have abnormal cardiac rhythms, in people who have psychiatric diseases such as schizophrenia, patients who have high blood pressure or need beta blockers for the protection against heart disease, require 2D6 for metabolism. A wide range of drugs used in the treatment of depression, and then certain medications that are used in the management of chronic pain. And this is by no means a fully inclusive list, and certainly not a list that you really should try and memorize at all. It's purely to give you an idea of the spectrum of different medications that are dependent upon CYP2D6 as a type of a cytochrome P450 enzyme for metabolism. And the reason I show you this particular cytochrome is because it gives me an opportunity to try and impress upon you some examples of how genetics interplays with drug metabolism. And this is certainly an issue that we will return to in later sessions. So in this particular example that I'm sharing with you is from approximately 10 years ago. And it was a study that looked at the metabolism of nortriptyline. And the normal metabolite of nortriptyline is 10-hydroxynortriptyline, which is shown over here. So what this study attempted to do was to look at plasma concentration here on the y-axis in both diagrams as a function of time on the x-axis, and compare individuals who have either no copies of the genes that encodes for this particular enzyme or multiple copies of the genes that encodes for the enzyme. And that's an example of polymorphism. So you can appreciate from this diagram that this particular curve here, which reflects an individual who has no copies, little in the way of functionality, of the 2D6 enzyme, or I'm sorry, of this 2D6 gene that encodes the enzyme, has much, much higher plasma concentrations and overall areas under the curve in comparison to individuals who have 13 copies of functional copies of the 2D6 genes. And what you have then in between is 1 copy, 2 copies, 3 copies, etc. So what this attempts to show is how genetic polymorphisms can alter the pharmacokinetic profile of the drug. In this example, altering the biotransformation pathways and the functionality of those pathways as a function of the genes that they possess. And over here on the right-hand side is a direct inverse. So for the individuals who have 13 copies of the genes, they get very high levels of the metabolite of nortriptyline because it's a hyper-efficient biotransformation pathway because there is so much 2D6, versus those who have no copies of the enzyme, you can see virtually no significant biotransformation to produce the metabolite of nortriptyline is occurring. So this is a nice example of where genetic polymorphisms is actually reflected in the plasma concentration of the drug over time. Are there certain populations that have a higher prevalence of 2D6 polymorphisms? Yeah, there are. Gene duplications are commonly seen in Saudi Arabians, Ethiopians, and then to a lesser extent in people of Spanish descent, Zimbabweans, Germans and Chinese. Poor metabolizers, lower copies of the enzymes, Caucasians and African Americans in the US. So what are the consequences of altered drug metabolism? Well, I think I alluded to this previously, but reduced metabolism could potentially result in toxicity or death. An example of this is thiopurine methyltransferase deficient patients if they're given a particular drug called azathioprine, which is an immunosuppressive drug used in the world of transplant medicine, or 6-mercaptopurine, and they are completely deficient of this enzyme. It can have a catastrophic effect on those patients. Increased metabolism, of course, can result in loss of efficacy if you're looking at that correlation between pharmacokinetics and pharmacodynamics, and the example I just showed you there was nortriptyline. Then I think it's important not to lose sight of the potential of drug-drug interactions. And in this situation, this is where one drug can inhibit or induce the metabolism of another drug. The example I gave you was a supplement with St. John's wort, but it also can be examples of antibiotics and their interaction with birth control. So let's stop here. I've just given you a pretty large body of information, and let's just see how we're doing. So if I were to ask you what is the primary purpose of metabolism, what would your answer be? Well, the correct answer is to terminate the action of the drug. But I think we also emphasized that biotransformation is important in the process of converting a prodrug to an active drug, or in the process of converting an active drug to an active metabolite. So I would like to summarize the overall points that I think are key to remember about metabolism, because it's a pretty large chunk of material that we've talked about in this session. 1, it's an important mechanism for terminating drug action. 2, metabolites are typically more polar and therefore more easily eliminated. 3, 2 distinct metabolic processes can occur, phase 1 or phase 2. Drugs can be subjected to both, can be subjected to one, can be subjected to both in any sequence. There can be substantial inter-individual variability in the activity of drug metabolizing enzymes. In addition, metabolism can be altered by drug-drug interactions, drug-diet interactions, drug supplement interactions, and also by specific polymorphisms in CYP enzymes. The extent of metabolism is an important determinant of efficacy and toxicity, and this interplay between the pharmacokinetic principle of metabolism and the pharmacodynamic principles of efficacy and toxicity will be detailed again and again throughout this pharmacology course. So at this point, I think we can say that we have shown that we can identify the primary sites of drug metabolism. I think we can say that we are able to describe the purpose of metabolism and the processes involved. And I think we can also say that we are able to describe the determinants of drug metabolism.